In the interest of time, we need to keep rolling along. Next up, we have Dr. Alfaze Omar, who also needs no introduction in this region, trained in the UK, research fellowship at Washington, D.C., and a well-known CTO operator here.
Thank you, Kwan. Good morning. Congratulations. Big meeting. I think last time I came from Tamduk meeting, and now it's grown so massive SIF meeting. Actually, I remember talking about bifurcation. I was in a fellows course in Las Vegas in 2010 or 2011. And there was a case, they go to like, fellows, what do you do? And there was a bifurcation. So I said, I'll stand the LED and maybe the diagonal or DCB. And I didn't realize at the time in America, you don't use DCB. And they're like, where are you from? So I mean, but like you said, we are so familiar with DCB, thankfully, in this region. I think we are maybe lacking our data, but experience-wise, I think we are very good. So DCB, bifurcation, great talks by all the speakers just now. So it accounts for bifurcation, accounts for 15% of lesions. So left main served LED is also considered bifurcation. And I think DCB has been very, interesting. I think there's a lot of good concepts in there, positive vessel remodeling, and that's what we've seen in our practice, vascular healing, late lumen enlargement, plaque reduction, and also simplifying your PCI procedure. I think that's very important. So it makes it much easier when doing clot, crush, decay, and all that. Sometimes, most of the time, you can make it more simple. So the rationale and advantage of DCB is more homogeneous drug transfer to the vessel wall, absence of stents, polymers. You don't have to worry too much about jailing your side branch, native geometry, vasomotor, and also shorter DAPT duration. There's a lot of reason why we will want to use DCB in our practice, more so in bifurcations as well. And I think Glendon was saying, I think the discussion was, the main thing is lesion preparation is the key here for DCB, because right at the end, the DCB would be just putting a drug to the vessel wall. Eng Han has mentioned about the consensus, so there are newer consensus, but usually what we do is that the key will be the preparation of the vessel. Okay, so you have to prepare to your comfort level between 0.8 or 1.0 1-to-1 ratio. So maybe the new consensus are 1-to-1 ratio, but do it gently. And I think the other thing will be making sure that you have orthogonal views to make sure there's no severe dissection that you may want to implant a stent. So flow limiting dissections are absent, residual stenosis less than 30%, and a good TME3 flow. And that's when we use your DCB in your bifurcation. Okay. Evidence are coming more aplenty now. So DCB versus POBA for side branches. So all the data suggests that DCB is definitely better than your normal POBA for your side branches. There are many data, PET-CAT beef as well. So I think generally it shows that the bifurcation lesions are much better when you POBA the side branch with DCB rather than just a normal balloons. And this is the key results from DCB BIF, where they use stent in the main vessel, like your LAD, and your diagonal. They compare between using your balloons or your DCB, and it shows a better results, better outcome when you use your DCB in your side branches. So I think very importantly is the patient and lesion selection and preparation. So this is the consensus, and we are very familiar. So you pre-dilate to make sure that you have a good MSA. So you have to have either normal balloons. More and more, we are going towards scoring and cutting balloons, atherectomy, so you can rota, OAS, and now we have lithotripsy and lytics and many more. So I think it's very important in DCB is that the lesion preparation is critical. Okay, so proper lesion preparation is key, 1-to-1 ratio, and then you can use atherectomy or IVL. Going to Kwan's initial question, I think scoring and cutting balloon is very important, and there's some data to suggest that when you're going to prepare for your main vessel, for your side branch, that you should, or you are being sort of use more scoring or cutting balloons. Okay, NSC alpha and sequence, please. So you can see the outcomes of using cutting and scoring balloons have better outcomes in your results. Usually for practice-wise, if you're going to approach DCB in side branch, you will prepare the vessel by any means to have a better vessel preparation, and we would tend to DCB the side branch first if you're going to treat it by DCB, just to prevent going the DCB to your side branch. So if you are going to prepare for a side branch and you're going to think about DCB upfront, then you might want to do this. However, sometimes you don't have plans to do DCB in your side branch, or you want to provide a side branch, then you will stent the main vessel and you pot and then you put in a DCB later. Sometimes it may have difficulty getting your DCB down, and sometimes there may be some drug loss as you go through the stent struts. But traditionally, this is the main way. You tend to treat the side branch with DCB first, and then you put in your main vessel stenting. Nowadays, there are more and more guidelines how for us to use coronary physiology and imaging in your PCI. So this was one of the live case we did for the CTO Live 8. This patient had triple vessel disease, apparently, from another center, and they say he's got left main, he's got LAD, he's got circ disease, he's got RCA disease, referred for bypass. So we brought in for the live case, and then when we did the LAD, the FFR was not significant, and the circumflex, it was significant. It's a very tight ostial circumflex lesion. FFR is significant, and we treated with a cutting balloon, a 3.5. There was mild wasting. We went up to a 4.0 NC balloon, and we put in a DCB of 4.015 at 6 atmospheres, and the post PCI FFR was 0.99. It's a very good angiographic results. And his RCA was also not significant. So someone's got triple vessel disease, planned for bypass. All we need to do is no stent, 1 DCB. That's how physiology and IVUS played so much importance for his outcome. About using rotational atherectomy, some data on this with DCB, and also with IVL and DCB in guiding your usage. So one of the patients, also in FFR, you can also use FFR, QFR in guiding. So after predilatation, you can measure your FFR, and if it's a pretty good FFR with good vessel, you might want to, that you can guide you for using the DCB as well. So once you prepare the lesion, and if the FFR is pretty good with no major dissection, you can consider DCB treatment. If there's decrease in flow or your FFR is very poor, then you may want to use a stent or scaffold. So this patient had 2 lesions, LAD and the diagonal. So after preparation, we had to, so before was FFR QFR was 0.76. We had to do rotational atherectomy. It was very calcified. Post was 0.91, the QFR. So in this case, we decided to DCB the main vessel because it was also having some myocardial bridging as well. So DCB, the main vessel, yeah. This last patient, okay, this guy had a PCI to his LAD and the circ, quite complex, I think by, I can't remember now, probably a DK crush or something. So DK crush, circ and OM and LAD stenting. He also had a further lesion at the distal PD branch. So instead of like putting another stent, you make it complex on the distal right to the RCA, just prepare with a scoring balloon and also a DCB. So the QFR was 0.79 pre-PCI, and then DCB 275, 40 in your PD branch in 2020. So repeated. So the FFR was good at 0.91. And a restudy in 2023, 2 years later, much better results. So we've seen a lot of positive remodeling, sometimes better than the immediate results. And when the follow-up, you see they have much better results. So the important is that you have to have adequate lesion preparation, delivery of DCB. That will determine your outcomes. It creates an environment for a homogeneous drug delivery to the lesions and improve the chance to have good outcomes after DCB delivery. So I think it's very important, the lesion preparation. The concept is very interesting and it makes sense because you try not to leave anything behind. There are a lot more studies going on looking at completely I think there's so many studies on board. I was checking on the internet about completely, like you say, left main LAD, DCB, main LED, and the diagonal. Currently, most of us are using more hybrid procedure because that's what we are comfortable with. And I think as more and more as time goes on, and we are more comfortable with the outcomes and the follow-up studies, then we might push the boundary even more to just leave nothing behind. And occasionally, I've done one or so, some left main DCB on one patient. So we are getting more and more comfortable with this technology, and also when to leave it, when not to leave it, because as what Enghan said, you want to create dissection, but not too much dissection that was going to limit the flow and cause acute vessel closure. So, okay, thank you very much. Have a good day.
Thank you very much for interesting topic. I have a small question for you. Besides for bifurcation, you DCB in side plan first, after you that's main plan. After the final result, your angiography, my result is not good for side plan. What do? You use kissing balloon or not?
Yes, I mean, sorry, miss you DCB for the side branch, then you extend the main vessel. Yes, then if the vessels are compromised, then I will rewire, I will use, and then I will decay. I will kiss with the side branch again. So it's okay to kiss, or it's okay to balloon a vessel that you have already DCB if there's compromise to the blood flow.
Okay. Thank you, because we have one time for discuss, so